Hello, my name is Peyman Hadji. I'm a professor of obstetrics and gynecology working at the Nordwest Krankenhaus in Frankfurt, and I'm a professor at the Philipps University of Marburg in Germany. The topic given to me today was bone health from menarche to menopause. On first hand, the incidence of osteoporosis, indicating that it's one of the 10 most frequent diseases in postmenopausal women. But the question is, when does the disease start? And do premenopausal women already comprise an increased fracture risk? In premenopausal women, let's say at the age of 20-25, there's always the question if contraceptives do have an impact on bone health. Well, what I showed is recent analysis indicating that oral contraceptives actually do not have an increased risk of fracture. The use of DMPA has shown in a number of studies a decrease of BMD, and we have performed an analysis of a large sample from the UK indicating that there's an increased risk of fracture, especially in the patients using it for a long time. Another group of premenopausal patients I've addressed are the ones with anorexia nervosa, as well as hypothalamic amenorrhea. Both patients group have a secondary amenorrhea and comprise a considerable loss of BMD in a very short time. Recent meta-analysis indicates that patients with anorexia nervosa have a 12-fold increased risk for osteoporosis, and though only short-term follow-up was comprised, patients had a 2-fold increased risk of fracture later on. Then, of course, patients with a premature ovarian failure also have an increased risk of fracture, which has been shown in a number of studies. I've presented a case of a patient with POI, which was treated with HRT and showed an increase of about 8% bone mineral density at the lumbar spine in only 1 year, indicating that yes, HRT is effective in patients with POI, especially at the bone site. In the final part of the presentation, I've focused on the perimenopause and the postmenopause. And of course, women after the menopause, due to the amenorrhea and the loss of estrogen function in the ovaries, lose considerable bone. And I've tried to show that the use of HRT is absolutely preventative in this regard. WHI study, but many other studies also showed that the use of HRT reduces fracture risk by about 50%. This is the concept of primary prevention, where we treat patients at high risk before the onset of osteoporosis and of course before the onset of fractures. If patients are already osteoporotic and have fractured, I've shown that there's a large number of medical interventions which are effective in the treatment of osteoporosis other than HRT. Finally, I've tried to focus on a very small group of patients with breast cancer who are treated with aromatase inhibitors. For these aromatase inhibitors, the increased incidence of fracture have been shown in many studies. Today we believe that 20% of patients on aromatase inhibitors will fracture in the course of 5 years of treatment. A number of studies have shown the effectiveness of bisphosphonates and very lately also denosumab in the prevention of fracture. And additionally to the reduction of fracture with the use of bisphosphonates in breast cancer patients treated with aromatase inhibitors, there is an effect on the breast cancer treatment. These patients have a 34% reduced risk of bone metastasis and a 70% increase of fractures. This underlines that estrogen and bone are really connected, and that estrogen depletion turns bone into osteoporotic bone and leads to an increased risk of fracture. Therefore, estrogen and bone are important, and estrogen substitution like HRT is effective in preventing fractures.